Dr. Niva, you are too late. Please start your talk.
I know. So, do you want me to talk, or do you want Dr. Umar to talk?
Dr. Umar Wahab will talk after your talk. So please
Okay,
start
let
your
me
talk.
share.
Thank you.
Let me share my screen, and please tell me if you can see it. Okay, is it like visible?
Yes,
Yes, it is
it's visible.
visible.
Yes, Niva, please start your presentation. Thank you.
I am starting, Dr. Usman. Just take a deep breath. I was late, you were not. So I'm really sorry, everybody. Due to some technical issues, I really had to, find another laptop and go for it. So I'm really sorry, and I'll just start without wasting much more times. It's a so today's topic is very it's different. It is very important, and I have been seeing this for quite a few. I have been noticing this for quite some time, that this thing. Diabetes distress, which initially I was myself confusing it a lot with maybe diabetes, depression because of diabetes. So this topic, when it came up to me, it was really interesting, and I really wanted to know what it is all about. So let's just start. I am Dr. Niba. Dr. Usman must have introduced. So let's just see what exactly is a diabetes distress. So now diabetes distress is also known as diabetes specific distress, or diabetes related distress. It's an emotional response to living with the diabetes and the burden of relentless daily self-management and the prospect of its long-term complication. Agar hum easily, if you want to look at in an easy way, it's very easy that, whenever you tell a patient you have diabetes, that sort of, the actualization and the realization that there is something that I have to deal with for whole of my life, and my lifestyle is just going to change, and I'll have to depend upon certain things. That feeling of impending doom, I would say that is diabetes distress. So now, coming up to this, a person with diabetes spends almost 168 hours per week or 720 hours per month managing their diabetes, be it in the form of the monitoring, be it in the form of going to the doctors or having their blood sugar level checks and stuff. It takes a lot of time, it takes a lot of resources, and it takes a lot of energy. I'm sorry, is somebody saying anything? Okay, so let's see how common diabetes distress is. Here I just went through an article, and it was basically an expert opinion, and it was telling that most of the people whom we see are the diabetics one, and we think that they have the major depressive disorder. However, when it was researched further, it was seen that only 4 to 6% of the patients, they had the major depressive disorder with diabetes, and the others had diabetic distress. So 1 in 4 people, which is very common, 1 in 4 people with type 1 diabetes have high levels of diabetes distress, as do 1 in 5 people with type 2 diabetes. So it's a very big number of that. And all of us who are seeing diabetes, we might agree that it's a little more than what's written here. So we might need to work over it as well. It's an important question: who is at risk of having diabetes distress? Now, everybody. So every patient who is diabetic is at a risk of diabetes, but there are few times at which this can be modified. What are the timings? First, it's around the time of diagnosis. Pata chala hai, it's big thing, and at the time of the diabetes. The second, at the emergence of a complication, a patient has a diabetes, he's going on, he's doing fine, and suddenly he finds out that he's retinopathy. That time, or adding to or switching a medication, be it starting an insulin, or be it adding to another drug, or going on the combination, then switching the healthcare plans, and then switching the healthcare provider, finding a new doctor, then whether you can trust him with your life or not. All these things, these few situations are those in which diabetes distress will be more. However, every person who is going to who is a diabetic is at risk for that. This is a very, this was a very interesting an article which I went through, and there were 7 reasons for diabetes distress. Basically, they were targeting the type 1 diabetics, but it applies to everyone. So first one was powerlessness. So it was that feeling that once blood sugar numbers, they have no power. The feeling that no matter how hard they try, they will never be good enough and they will never be able to fight this disease. So that is the powerlessness. This is the one reason. The other is negative social perceptions. That is, it's very common that, especially in the females, that they have to hide diabetes from the patients, from the people around. What would they say? उनको पता चलेगा तो diabetes का क्या होगा? बेटी की मैंने शादी करनी and all that stuff. So negative social perceptions, and all of us, we have been going through this. We have known one or other patient who have this. Now the other thing is physician distress. So physician distress is basically that if the patient thinks that the doctor is not able to help him out in this situation. So it's a disappointment with the current health provider. Then friend and family distress, that there is too much or too little attention paid to the diabetes. Either they make a bigger deal out of it, oh my God, you have diabetes, your life is ruined or something, or they don't care at all. Acha koi baat nahi, dekha jayega. So it can be either of the two situations, which can lead to distress. Then hypoglycemia distress. This is actually a big thing. The concerns about severe hypoglycemic events, especially after somebody has an episode of distress, episode of hypoglycemia, especially when somebody has already had an episode, then hypoglycemia distress genuinely kicks in. And it's like that they feel that they can never be safe from the possibility of another serious hypoglycemic event. This is one of a major reason why your patients might not want to go on injectable or insulin or anything, because they would say कि sugar तो बहुत कम हो जाएगी, so क्या किया जाए? So this is actually a reality kicks in. Then management distress. Patient is disappointed with own self-care. He's not satisfied. He's like, I don't know how much attention should I pay to diabetes. It doesn't matter, because whatever I do is not good enough. I am not good enough for me. I am not able to control it. Then eating distress. Eating distress is, I think I have, anybody of us who, okay, let me talk about myself. If I feel like that I have to, lose a few kgs, a few pounds, and I should not eat stuff. That this is not very easy to do. Like, oh my God, I cannot control what I can eat, and that's only just because this is not a disease. I just want to be healthy. So if somebody has an eating distress when it's a diabetic patient, it is the concern that one's eating is out of control. They cannot eat what they want to, they cannot eat when they want to, and they cannot eat how much they want to. This adds to a distress. So that article's actually summed up 7 important points that we need to see that these cause the distress. Now, signs and symptoms of the distress are patient, they feel angry about diabetes. Mujhe kyun ho gaya? Why me? Why me? Why not somebody else? And frustrated that it demands a lot of managing. Then worrying about not taking enough care of your diabetes, but not feeling motivated to change. So they would tell you, okay, yes, I got to know that I'm diabetic 2 years back, but then I didn't check my blood sugar level, because they don't want to face the reality. They're just distressed so much. Then avoid going to appointments or checking your blood sugar level. आंखें बंद करने वाली जो बात होती है. Then making unhealthy food choices regularly. Very common practice. Everybody who is seeing diabetes, आपको पता होगा, they would say, बस मैंने 2 लुक में ही चखे थे. उन्होंने, मैं जी किसी के घर गेस्ट गई थी, उन्होंने बहुत इसरार किया.
हैप्पी मीटिंग मेरे ऑफलाइन.
Okay, somebody's mic is on. Please switch it off so I can continue with my presentation.
Yeah, Dr. Nimbe, actually we have a muted all, and only co-host can unmute yourself. Now you can unmute yourself and you can speak easily. Thank you.
Okay, is it fine?
Yes.
Okay, so I was talking about making unhealthy food choices regularly, and then feeling alone and isolated. And I think if we talk about type 1 diabetic patient, let's see, it's a child, and has some school activity or a school festival or anything, and the child has to, you know, refrain from some things, and he or she cannot eat maybe a cupcake or a soft drink or anything which is sweet, and children love it, obviously we know that it will lead to a diabetes distress in that patient. So all of these things we need to understand that they constitute the diabetes distress, and they are very much prevalent where we live and the patients we deal in. Sometimes we do not have time to listen. Sometimes we do not have, you know, we do not know that we are looking for this. The main point which I want to make today is, if we know that this exists, we will look for it in our patients, and we can make a difference actually. This is what patients feeling is about, you know. This is in the word of the patient. I think the hardest thing was, as soon as you start checking your sugars and you do not watch them go down, that just becomes blow after blow every day. It's not something you deal with every 3 months when you get your blood test results. It's something you're dealing with on the daily basis. Very important, very important. So it's taken me a long time to get used to doing sugar readings and accepting them. Now I would sometimes we are you know, we say that patients, they want मुझे जल्दी से ठीक हो जाए, आज मैं डॉक्टर के पास गया हूँ, कल मेरी शुगर ठीक हो जाए, and then we would talk with each other के ऐसा नहीं होता, it takes time, we understand, patients don't understand. That's correct, but what we do not understand is this thing, that they have that this diabetes distress in them, that they want it's enough, the next time I check my sugar, please it should come back, and when it doesn't, it you know, causes stress in them. This is a video. If I don't know, if I'm just playing, just see what she has to say. Just listen to what she's saying.
Probably the biggest feeling that diabetes brings out in me is annoyance. It's just, it takes up too much of my time, of my brain space. I'd rather be doing other things. Unless you've got people in your family, I suppose, or a friend who's diabetic, no one really knows. It's like, I don't really feel like it. I don't want to make that at home. Always having to think about what you're eating, what you're doing, where you're going, have you got food for this, have you got an emergency snack, testing my blood, the tablets or the insulin or whatever. That constant thing at the back of your mind. And sometimes you just want to press the pause button to check the blood before I go to bed. I was originally diagnosed with diabetes when I was 37 weeks pregnant. 2 days later I had the baby. I wasn't diabetic anymore. The second child, as soon as I had the baby, the gestational diabetes went. The following January, both my children and my husband all got chickenpox at the same time. And so I was trying to, you know, look after everybody. And then in the middle of all of that, my mother suddenly died. Then it wasn't long after that I was tested again, and it turned out it was type 2 diabetes. And it was a really horrible time. I didn't realise it was so life-threatening. I didn't realise it was so serious. I didn't realise how it affected pretty much every bit of your body, or it could do. I suppose it was just much harder than I thought it would be. It's like never going to fill me up. That's never going to fill me up. I just built up this resentment over the years of going to have my HbA1c test results and being told that, yeah, they're still not very good. No, you still need to work on it. It was all very matter of fact. Now I'm not sure whether I'm restless and my heart's going because I walked up the hill, or sometimes I just want to cry in frustration because I can do exactly the same thing. Like I have exactly the same breakfast every day, and one day I'll have a hypo after it, and one day I won't. I just became really emotional, started crying when she gave me my test results because they just kept going up. And I was like, gosh, is it ever going to go down? She asked me if I wanted to see a psychologist. I didn't even know there was a psychologist. And I thought, yeah, leapt at it because I thought anything to help me. And I started seeing the psychologist. One of the things that really made me feel better, I think, was just hearing her say that I wasn't doing everything wrong. It felt like someone who understood what it's like. The emotional support's been important because it's made me feel not so isolated. It has made me feel that to stop blaming myself as well. Some things I can't control. I'm still working on it. It's still hard for me. It's still a struggle. But having a sympathetic ear makes it much, much better.
I think
Probably the
this this video has actually summed the reasons. She has actually given words to them, and I really, there were two sentences that really hit me very hard. Number one, that she wanted to pause a little, that she wanted a little break from all that routine of hers and all that stress and everything. She wanted a little pause. The other thing she said at the end was that if you have an understanding or empathic ear, somebody listens actually to what you're saying, it makes a difference. So diabetes distress is actually amalgam of defeat, denial, feeling of loneliness, low motivation, frustration, fear, all of this combined. And we need to understand that we cannot actually treat a patient of diabetes without addressing diabetes distress, because that stress would add on to maybe a compromised management, a compromised control, and obviously not, that would be a vicious cycle, I would say. It would lead to more complication, more uncontrolled diabetes, and more diabetes distress. So it has to break at one point, and it cannot break unless we realize that it's an entity that needs to be taken care of. Very important question. This was the question that I really had in mind. It's basically, I did not have this question in mind. I knew it for sure that obviously this is depression. I did not think initially, when I did not know about it, that the diabetes distress is one entity and depression is one entity. And I would say that at this moment, even I don't know, maybe I'm overcommitting, but 70 or 80% of us treating physicians, they are unable to differentiate between, is it depression or the diabetes distress. So let's see, diabetes distress is not the same as depression. It is when a person feels frustrated, defeated, or overwhelmed by diabetes. An interesting point is that these feelings can come and they can go, and it does not mean, this is most important, that it does not mean that you have these feelings about the other parts of your life. A person, if he or she is depressed, he or she is depressed for each and every aspect of the life. Person with diabetes distress would feel frustrated and defeated and overwhelmed by diabetes, but the rest of the areas of the life, they're fine. But this diabetes distress can turn into depression if you have these feelings for a while and they are not going away. So you have to intervene. Somebody has to intervene for this. This is my last slide. It is a little, overcrowded stuff, but I'll just tell you one point. So CRH, ACTH is released, which causes release of cortisol. The cortisol, which is released in response to, in response to stress, that stimulates the formation of glucose and glycogenolysis, sorry, and it would lead to high blood glucose level. This is the vicious cycle I was talking about. If the patient is in stress, it will ultimately lead to uncontrolled blood glucose or HbA1c, whatever you want to say, and this will then again increases the distress. We have to intervene. We have to stop this cycle. We have to break it. And we can only break it if we actually know what it is all about. So this is my last slide. I just had to give you an overview of what diabetes distress is, so that our next speaker can take over from that. I'll hand it over to Dr. Usman, please.
So we can't manage diabetes without addressing diabetes distress. Thank you, Dr. Oniba Sayed, for such a comprehensive talk. Now, for second talk, I will request our second speaker, Dr. Umar Wahab. Dr. Umar Wahab will discuss the management of diabetes distress. Over to Dr. Umar.
Assalamu alaikum. Thank you, Usman, and
थैंक यू डॉक्टर अनीबा, आपकी बहुत जो है, थैंक यू फॉर द वंडरफुल प्रेजेंटेशन. Diabetes, you know, is a big problem in Pakistan. Pakistan is now ranked third in the world with the highest number of diabetics, and this is so unfortunate. And शायद इस चीज को अगर अब जो है वो कंट्रोल ना किया गया, then काफी चीजें शायद हमारे हाथ से निकल जाएंगी. We all know कि क्या रीजंस हैं इसके पीछे, अवेयरनेस का ना होना, एंड जो ये टॉपिक है डायबिटीज डिस्ट्रेस, ये शायद हमारे पेशेंट्स में, शायद पाकिस्तान में रहते हुए, इट्स लाइक अ ह्यूज प्रॉब्लम. दे डोंट अंडरस्टैंड कि किस किस्म की ये डायबिटीज उनको हुई होती है, एंड दे डोंट अंडरस्टैंड कि हाउ टू मैनेज इट, बिकॉज जो हमारे हेल्थ केयर professionals हैं, unfortunately they didn't used to spend the quality time with your patients, जिसकी वजह से पेशेंट इन चीजों को अंडरस्टैंड जो है वो नहीं कर पाता अनफॉर्चुनेटली, एंड देन पेशेंट एंड अप इन हैविंग द कॉम्प्लिकेशंस, एंड जो है जब उनको ये कॉम्प्लिकेशंस जो है डेवलप हो जाए, देन जो है डिस्ट्रेस, एंड इसके साथ इमोशनल पे डिस्ट्रेस, फाइनेंशियल जो है वो डिस्ट्रेस, और ये सारी चीजें इतने एडअप कर जाती हैं कि पेशेंट एंड अप एंड ना सिर्फ अपनी अपनी जिंदगी उसकी इफेक्ट होती है, बल्कि पूरी जो फैमिली है वो भी सारी इफेक्ट करती है. तो आई विल गो विद द कॉन्सेप्ट ऑफ salutogenesis. You, I don't think so कि a lot of people have heard about salutogenesis. मैं आता हूँ हाइपोग्लाइसीमिया के ऊपर, मगर मैं एक चीज सिर्फ बताना चाहूँ कि we all have heard about the pathogenesis. Pathogenesis means कि उसकी abnormality क्या है, but salutogenesis ये होती है कि हम उसको उसकी जो अच्छापन है या वेल बीइंग है उसको कभी किसी ने जो है डिस्कस नहीं किया. और पेशेंट को अगर हम salutogenesis के कॉन्सेप्ट पर लेकर चलेंगे तो बहुत सी चीजें हल हो जाएंगी. सो जी मैं आऊंगा उसके ऊपर. ये मैं आखिर में चीजों को डिस्कस करूंगा. आई वुड लाइक टू गो विद द फर्स्ट स्लाइड ऑफ हाइपोग्लाइसीमिया. The fear of hypoglycemia, we all know what is hypoglycemia, and hypoglycemia, जब मैं पाकिस्तान आया था तो हमारे यहाँ पर इंसुलिन एक बहुत बड़ा स्टिग्मा था. इंसुलिन को एडवाइस नहीं किया जा पा रहा था, एंड पेशेंट्स की ओन पर भी और जो हमारे हेल्थ केयर प्रोफेशनल्स थे उनके ओन पर भी ये चीज थी कि हाइपोग्लिसीमिया कैन कॉज अ लॉट ऑफ प्रॉब्लम्स, जिसकी वजह से जो है वो ओरल मेडिकेशंस की टाइट्रेशन वो प्रॉपर एट द टाइम जब उनको जरूरत होती है वो नहीं की जाती है, और पेशेंट की जो टाइम इन रेंज का जो कॉन्सेप्ट आजकल आपको नजर आता है वो शायद उन पेशेंट्स में अचीव नहीं कर पाया, जिसकी वजह से कॉम्प्लिकेशंस की जो वैल्यू थी वो काफी ज्यादा जो है वो इंक्रीज करती गई. द फियर ऑफ हाइपोग्लाइसीमिया developed for so many reasons, you know, the understanding. Uneducated people हैं हमारे यहाँ पर. I also मैं तो जो है एक फाउंडेशन भी रन करता हूँ जिसके लिए जो यहाँ पर एजुकेशन एंड जो अवेयरनेस है डायबिटीज की वो काफी इम्पोर्टेंट होती है. उनको कुछ मालूम नहीं होता कि व्हाट इज हाइपोग्लाइसीमिया, और हाइपोग्लाइसीमिया के जो साइन और जो सिम्टम्स हैं वो क्या होते हैं. तो हमें पेशेंट को अवेयर जो है वो करना पड़ता है कि व्हाट इज हाइपोग्लाइसीमिया. अगर उनको अवेयरनेस वो नहीं होगी, then end up in having but hospitalizations and having the loss of consciousness as well. और जब उनकी और another thing which I want to say here कि हमारे पास HbA1c almost 14 प्लस के पेशेंट्स आ रहे होते हैं काफी. तो उनके अंदर अगर हम ये बताएं कि जी आपको जो है वो ट्रेमर्स होंगे, you may feel some sort of जो है tremors and sweating और palpitations, तो वो शायद जब अगली दफा हमारे पास विजिट करने आते हैं, दे यूज्ड टू प्रेजेंट कि हमें हो रहे थे, एंड मीन और हमने फिर चेक नहीं किए. तो वो चेक ना करने के आपने ये तो बता दिया कि जब ये चीज होगी देन यू हैव टू टेक समथिंग फॉर टू ओवरकम इट, मगर आप ये ये शायद नहीं बता पाते हम लोग कि आपने उस वक्त चेक जरूर करना है कि आपकी कितनी वैल्यूज पर आपको हाइपो के एपिसोड आ रही होती हैं, बिकॉज यहाँ पर बहुत हाई लेवल्स पर हमारे पास पेशेंट जो है वो प्रेजेंट करते हैं वंस दे हैव जो है 120 या नॉर्मल उनकी जब वैल्यूज आती हैं तो दे मे फील द हाइपो एपिसोड्स एट द नॉर्मल वैल्यूज, जिसकी वजह से शायद हाइपो को प्रॉपर्ली एजुकेट ना करने की वजह से पेशेंट जो है वो दोबारा से आपके साथ हाइपोग्लाइसीमिया के साथ आ रहा होता है। ओके जी, अगली स्लाइड लगाइएगा प्लीज। So personality, okay, the previous experience of traumatic hypoglycemic episodes, especially the one which is the complicated one and end up in having the admission in the hospital, are या फिर जो है लॉस ऑफ कॉन्शियसनेस या फिर वो उसको नॉक्टर्नल हाइपोग्लाइसीमिया अगर हुआ था, तो ये वाली जो फियर है, बिलीव करें आपका पेशेंट शायद अगली दफा आपके पास आएगा भी नहीं। तो ये चीजें आपने अवॉइड करनी है और उनमें सही जो मेडिसिन है एट द राइट टाइम इनिशिएट करना है। फिर उसमें आपने जो हाइपोग्लाइसीमिक मेडिसिन हैं जो स्पेशली सल्फोनाइल यूरियाज हैं या फिर इसमें हमारे पास इंसुलिन हैं, वो आपने प्रॉपर्ली एजुकेट भी करनी होंगी। तो ये जब तक आप उनको प्रॉपर एजुकेट नहीं करेंगे, उनके फियर ऑफ हाइपोग्लाइसीमिया जो है वो उनके अंदर रहेगा, जिसकी वजह से उनकी जो ग्लाइसीमिक जो वेरिएबिलिटी है वो रहेगी, जिसकी वजह से उनके ऑर्गन्स जो है वो अफेक्ट होंगे। नेक्स्ट स्लाइड। So type 1 I'm also running a phone there is हमारी एक जो है वो डायबिटीज के नाम से एक जो है टाइप 1 का ग्रुप है, और उसमें बिलीव करें हमें हर रोज ये जो है इस किस्म के लोग, हमें छोटे बच्चियां जब मिलती हैं और वो हमें ये बताती हैं कि उनकी हाइपो और हाइपर आ रही होती है। सो अनफॉर्चुनेटली यहाँ पर हमारे पास जो सीजीएम्स हैं वो अवेलेबल नहीं है, या जो फ्लैश मॉनिटरिंग है वो अवेलेबल ना होने की वजह से हम उनको प्रॉपर्ली जो है वो मैनेज नहीं कर पा रहे हैं। सो टाइप 1 को एजुकेट करना, उनको फियर ऑफ हाइपोग्लाइसीमिया से आजाद करना, ये बहुत इंपॉर्टेंट है, बिकॉज दे आर ऑन इंसुलिन। जब वो इंसुलिन पर हैं तो जो हेल्थ केयर प्रोफेशनल और जो डायबिटीज एजुकेटर का रोल है वो बहुत ज्यादा हाई हो जाता है। तो आप लोगों ने उनको एजुकेट करना है, उनके साथ काउंसलिंग करनी है और रेगुलर इन टच रहना है, उनको बताना है कि fear of hypoglycemia को कैसे रिड्यूस किया जा सकता है। You don't have to fear the hypoglycemia, you just have to manage it at the right time। और उनकी हाइपो और हाइपर की वैल्यूज को हम इसमें जो फ्लैश मॉनिटरिंग है या सीजीएम्स हैं, ये कोशिश पाकिस्तान में अभी हो रही है। इंशाल्लाह बड़ी जल्दी एक चीज आप लोग को जो है ये चीज मिलेगी कि पाकिस्तान में अब वो चीजें भी आना जो है वो शुरू हो चुकी होंगी, जिसकी वजह से हाइपोग्लाइसीमिक की जो एपिसोड्स है काफी हद तक रिड्यूस हो जाएंगी। देन देयर इज अ प्रॉब्लम विद टाइप 2 डायबिटीज, और स्पेशली वो लोग जो कि ओरल्स पर रहते हैं, और ओरल भी जो है ऐसी मेडिसिन जो कि काफी ज्यादा हमारे पाकिस्तान में सल्फोनाइल यूरियाज की स्ट्रेंथ बहुत हाई दी जाती है, जो कि इंटरनेशनली जो है वो रिकमेंड नहीं की जाती। अनफॉर्चुनेटली उनको प्रॉपर मेडिकेशन पर होना चाहिए। ये चीजें आपने उनको फिर एजुकेट करना है। और ये सारी चीजें करती क्या है? ये सारी चीजें ये करती हैं कि उनके अंदर एंजाइटी के उनके अंदर डिप्रेशन, एंजाइटी, टेंशन, ये सारी चीजें एग्रोवेट जो है वो उनके अंदर हो जाएंगी, और ये सारी इंटरमिंकल्ड होती हैं, इंटर कनेक्टेड हैं विद दी हाइपोग्लाइसेमिक एपिसोड्स। तो इनको ये मालूम नहीं हो पा रहा होता कि ये एंजाइटी की वजह से हो रहा है और या फिर ये बेसिकली हाइपोग्लाइसेमिक रियल एपिसोड चल रही है। तो इसमें भी काउंसलिंग और इसमें सल्यूटोजेनेसिस का रोल जो है वो काफी इंपॉर्टेंट होगा। आपने पेशेंट के साथ टाइम स्पेंड करके पेशेंट की साइकी को रीड करना है, उनसे उनकी प्रॉब्लम्स को जो है वो पूछना है, उसको फिर उसके बाद उसके मुताबिक एसेस करना है, और उसकी असेसमेंट के बाद उसको एड्रेस करना है। तो ये तीन चीजें हैं, तीन एज हैं। You have to ask the patient, you have to assess the patient, and you have to जो है वो फिर डायरेक्शन देनी है, उनको सही डायरेक्शन की तरफ लेकर चलना है. नेक्स्ट स्लाइड. I have already informed you कि जो हाइपोग्लाइसेमिक के जो एपिसोड्स हैं, इट ऑलवेज जो है एंजाइटी या टेंशन की जो सिम्टम्स होते हैं उसको ओवरलैप जो है वो कर रही होती हैं. सो देयर शुड बी एन एजुकेशन एंड अवेयरनेस फॉर दैट. और उसके लिए फिर जो है ग्लूकोज की मॉनिटरिंग, एसएमबीजीज जो है वो बहुत इंपॉर्टेंट होती हैं, वेदर दिस इज टाइप 1 या टाइप 2. तो आपने प्रॉपर्ली एजुकेट करके उनको बताना है कि अगर ये चीज होगी देन यू हैव टू फाइंड इट आउट कि वेदर यू हैव the real episode of hypoglycemia or is it only the anxiety or tension. And it actually aggravates, the episode of hypoglycemia can actually aggravate the anxiety as well. Next slide. The absence of fear can also be a problem, you know. A few people I have seen here in Pakistan जो कि ये शायद इस चीज को अंडरस्टैंड नहीं कर पा रहे थे कि ये जो है हाइपोग्लिसीमिया भी कुछ होता है, और इसमें फिर और वो इस चीज को अंडरस्टैंड करना ही नहीं चाह पा रहे थे. वो कहते हैं कि ये नॉर्मल है. तो इसमें भी फिर रोल एजुकेशन और फिर जो है अवेयरनेस का आता है. एंड दे आर नॉट रियली कंसर्न्ड अबाउट इट. वो समझते थे शायद ये नॉर्मल है. तो ये नॉर्मल उनको ये क्यों महसूस हुआ? क्योंकि उनकी हाइपो भी हो रही थी, हाइपर भी हो रही थी. जो एजुकेशन है उनको ये पता नहीं है कि खाने से पहले की शुगर की क्या वैल्यूज होनी सकती है मिनिमम, और कहाँ तक ये मैक्सिमम जा सकते हैं, और खाने के बाद की शुगर की कहाँ पर मिनिमम और मैक्सिमम बता सकते हैं. सो मिनिमाइजिंग द कॉन्सिक्वेंसेस ऑफ impaired awareness of hypoglycemia, they actually believe that they function well even when their glucose level is below 3 millimoles, which is equivalent to 60 milligram. सो ये चीजें जो है वो हमारी एजुकेशन और अवेयरनेस से एड्रेस होंगी. और वी हैव टू मतलब ये पेशेंट की काउंसलिंग इज सो इम्पोर्टेंट टू ओवरकम दी डायबिटिक से रिलेटेड जितने भी डिस्ट्रेस कॉजिंग फैक्टर्स हैं. एंड इसमें जो सबसे इम्पोर्टेंट फैक्टर है वो बेसिकली हाइपोग्लाइसीमिया है. नेक्स्ट वन. Their beliefs and attitudes are likely to prevent people with diabetes from being motivated to regain the awareness and minimize severe hypoglycemic events. So beliefs और attitudes को change किया जा सकता है once you understand कि वो patient क्या feel कर रहे हैं. वो patient को पहले पूरा listen करें, आप उसको पहले पूरा ये सुने, उसको ये time दें, और फिर उसको अंडरस्टैंड करें, उसको कहें कि वी अंडरस्टैंड व्हाट यू आर एक्चुअली गोइंग थ्रू. और उसके बिलीव्स जो हैं वो सारे जो है समझने के बाद उसको आपने प्रॉपर तरीके से विद द लॉजिक आपने उसको एजुकेट करना है कि ये चीजें ऐसे ऐसे नहीं थी, इसको ऐसे करना चाहिए आपको. तो ये चीजें इट विल टेक सम टाइम बट इट विल रिजॉल्व इंशाल्लाह. नेक्स्ट वन. Aware, you have to aware the patient, you have to ask the patient, and you have to assess the patient. And then there's another one, you have to address the patient's issues. Next one. So what is be aware? So diabetes distress can present itself in so many ways, you know. What are the common signs to look for it? Suboptimal HbA1c, unstable उसकी basically जो home monitoring values है उसको देखना पड़ता है. Not attending the clinic appointments, reduce engagement with diabetes, self care जो tasking उसको दी गई है, like उसमें जो monitoring of the जो है जो values है, and skipping the medications, ineffective coping strategies for dealing with stress, emotional eating. कुछ लोग ऐसे भी होते हैं जिनको ये फील होता है कि जैसे हमें हाइपो में जा रहे हो, वो इमोशनली उनको ज्यादा खाने पीने करते थे, या कुछ ऐसे मैंने ऐसे लोग भी देखे हैं जो एंजाइटी में ओवर ईट करते हैं. एंड देयर आर सो मेनी other stresses like financial problem, it is a big problem here in Pakistan. Unemployment, homelessness, ये सारी चीजें बड़ी रहती हैं. Impaired जो है relationship with the healthcare professionals and partners and family or friends, and appearing to be passive or aggressive during the consultations. So these things, you know, ये सारी वो चीजें हैं जो आप अपने पेशेंट्स में वो देख रहे होते हैं. मगर अगर आप पेशेंट को एटलीस्ट 5 to 10 10-15 मिनट देंगे ना, तो ये सारी चीजें आपको उसके अंदर महसूस होंगी कि HbA1c वो कंट्रोल क्यों नहीं कर पा रहा. उसकी HbA1c क्यों कंट्रोल नहीं है? बिकॉज ही इज हैविंग इमोशनल स्ट्रेस. उसकी HbA1c क्यों कंट्रोल नहीं है? उसके अंदर क्योंकि उसको अवेयरनेस नहीं है. उसके अंदर उसको खाने पीने का पता ही नहीं है कि क्या चीज लेनी चाहिए, क्या चीज जो है वो नहीं लेनी चाहिए. फाइनेंशियल इश्यूज पाकिस्तान में बहुत चल रहे होते हैं. तो ये सारी चीजें एड्रेस करने के लिए उसको पहले आपको अंडरस्टैंड भी करना है और उसको अवेयर भी करना है. नेक्स्ट वन. नाउ यू क्या पूछ सकते हैं पेशेंट से? व्हाट यू कैन आस्क टू ओवरकम डायबिटीज डिस्ट्रेस. क्या पूछना चाहिए पेशेंट से? क्या सवाल करने चाहिए? दिस इज सो इम्पोर्टेंट. यू नो, व्हाट इज द मोस्ट डिफिकल्ट पार्ट ऑफ लिविंग विद डायबिटीज फॉर यू? पूछिए उनसे कि जब आपको ये शुगर हुई है तो आप क्या समझते हैं कि आप शुगर की वजह से क्या चीज सबसे ज्यादा मुश्किल हो गई आपके लिए. देन यू कैन आस्क कि क्या सबसे ज्यादा इशू किस चीज के साथ आ रहा है. आपको क्या लगता है कि क्या चीज आपको डायबिटीज जो है कंट्रोल नहीं करने दे पा रही. या फिर आप उससे ये पूछ सकते हैं कि कोई ऐसी और भी बात है, आप मुझसे जो है वो इस चीज को भी डिस्कस करो, ताकि हो सकता है उसके अंदर कोई इमोशनल को बिहेवियरल का या कोई सोशल डिफिकल्टीज हो जो आपको बताने के बाद वो शायद वो रिलैक्स हो जाए. उसके बाद उसकी जो इमोशनल जो डायबिटीज का जो डिस्ट्रेस फैक्टर है वो हल हो. And express how particular diabetes related issues are causing them distress. याद रखिए, जब पेशेंट एंजाइटी या डिप्रेशन में होता है ना, तो वो ये चीजें कभी भी नहीं जो है वो सुनना चाहेगा कि उसको एंजाइटी हो गई है या डिप्रेशन हो गया, और अगला बंदा उसको ये एहसास दिलाए कि ये तो मतलब हमें ये सारा का सारा जितना भी कसूर है वो सारा उस पर डाल रहा है, और वो अगली दफा फिर आपके मतलब आपसे बात नहीं करेगा. आपने ये कहना है उसको कि यस वी अंडरस्टैंड कि आपके सारे प्रॉब्लम्स चल रहे हैं. यस वी अंडरस्टैंड कि देयर इज अ प्रॉब्लम ऑन आवर पार्ट एज वेल. हमारी वजह से ये चीजें आपके साथ हो रही हैं, और हम आपको ये एहसास दिलाते हैं कि हम आपके लिए बैठे हैं इसको हल करने के लिए. दीज आर द वर्ड्स, यू नो. दिस इज कॉल्ड सैल्यूटोजेनेसिस. जो मैंने आपको स्टार्टिंग में बात बताई थी, सैल्यूटोजेनेसिस ये होता है जब आप उस चीज का एहसास दिलाएं कि वी केयर फॉर यू, तो वो बंदा फिर जो है वो डायबिटीज को हल भी करेगा और उसको प्रॉपर्ली और उसके प्रॉब्लम से भी निकलेगा इंशाल्लाह. नेक्स्ट वन. So to assess how to assess, there's a lot of जो है questionnaires available all over the world. तो ADNA जो है there is a screening form for that. I was there to attend that, और मैंने जो है वो ये सेशन शायद मैंने अटेंड भी किया था. I remember that. उसमें एक स्क्रीनिंग जो है ये फॉर्म था. Next one. And in this screening form we it will be shared with you all, जिसमें हम स्कोरिंग जो है स्कोरिंग का सिस्टम रखा है हमने. इसके बाद हम ये असेस करते हैं कि पेशेंट किस किस्म की जो है डिस्ट्रेस में चल रहा है, और इसमें फिर कुछ स्कोरिंग ऐसी है जिसमें हम इमोशनल जो बर्डन है उसको असेस कर रहे होते हैं. इसी तरह जो फिजिशियन का डिस्ट्रेस है उसको भी देख रहे होते हैं, एंड द रेजिमेंट डिस्ट्रेस. कुछ डॉक्टर्स ऐसी जो है वो ट्रीटमेंट लिख देते हैं जिसके लिए शायद पेशेंट राजी नहीं होता. आई एम टॉकिंग अबाउट इंसुलिन. यू नो, yes, patient need it. This is the most important जो है insulin is the most important thing, but you have to consult the patient on each and every visit. आपने उसका माइंड डेवलप करना है कि वो इंसुलिन के लिए राजी हो जाए. इफ ही इज नॉट रेडी फॉर द इंसुलिन एंड यू आर राइटिंग द इंसुलिन, बिलीव माय वर्ड्स, तो शायद एक दफा इंसुलिन लगाएगा, दूसरी दफा उसके अंदर फियर आ जाएगा, एंड देन ही विल नॉट बी स्टार्टिंग इंसुलिन. यस, you can start with the single dose. Yes, you can start with something else. उसको थोड़ा सा ये बताया कि pain is not a factor, you know. Insert it on yourself first. अपने आप को एक इंजेक्शन which I used to do it sometime, कि मैं अपने आप को लगाकर इंसुलिन जो है वो एड्रेस में कर लेता हूँ, और ताकि पेशेंट का जो फियर है वो रिजॉल्व हो जाता है. नेक्स्ट वन. So your slide, yes, the 5I approach. I gave a presentation on salutogenesis almost 2 years back, before COVID, और मैंने वो सारी स्लाइड्स ऐड नहीं की, बट द 5I अप्रोच इनिशिएट जो है आपने उस पेशेंट के साथ जो है डिस्कशन इनिशिएट करनी है, उसको ये एक एटमॉस्फेयर देना है कि वी care for you, identify the source and the degree of diabetes distress, inform the means of minimizing it, incorporate healthy coping skills, and improve the quality of diabetes care and support. Next one. And most important thing, watering the plant of communication. So welcome warmly. जब मेरे पास पेशेंट आता है, I used to stand up and I used to greet him. ठीक है, तो आप एक अच्छा जो है वो जेस्टर के जरिए आप उसकी तकरीबन वो डिस्ट्रेस की पोजीशन ऑलमोस्ट हाफ कर देते हैं. आस्क एंड असिस्ट एंड जो है टेल, जो है उसको उसके साथ सच बोलें. यस, ही सच मुश्किल होगा, मगर शायद वो अंडरस्टैंड करके अपनी प्रॉब्लम्स को हल कर पाएगा. एक्सप्लेन विद एम्पैथी बट नॉट विद सिंपैथी. एम्पैथी उसके साथ जो है, यस वी केयर फॉर यू, एंड देन जो है फिर आखिर में फिर जो है रीअश्योर एंड फिर उसको के दोबारा भी आपने आना है. ये चीजें जब आप करेंगे तो डेफिनेटली इट विल इंप्रूव द पेशेंट हेल्थ. नेक्स्ट वन. So minimizing the discomfort of change, achieve concordance between the felt needs and the actual needs. उसके लिए क्या जरूरी है, उसके लिए क्या होना चाहिए, ये दो अलग चीजें हैं. आपने उस चीज को जो है वो अपने मतलब अपने पेशेंट को बताना है तुम्हारे लिए क्या जरूरी है और क्या होना चाहिए था. Abbreviate the bad news and prolong the pleasant news. Yes, डायबिटीज तुम्हारी कंट्रोल नहीं, बट वी कैन डू अ लॉट, आप ये कर सकते हो. ये सब चीजें आप उनको बतानी है. देन यू हैव टू प्रेज एंड जो है उसके अंदर ये प्राइड लेकर आओ कि ही कैन डू इट. अलाउ कंटेम्पलेशन ऑफ चेंज, एक्सेप्ट करे वो चेंज को. चेंज को एक्सेप्टेंस भी होनी चाहिए, सबटल चेंजेस होनी चाहिए, स्मॉल बिट्स में होने चाहिए. सब कुछ बदल दें आप उसका, क्योंकि शायद जो पिछला डॉक्टर तो कुछ भी नहीं आता था उसको. And do not enforce the change and end on the pleasant note. Yes, please. Thank you करके अगर आप उसको भेजेंगे ना, और या फिर जज़ाकल्लाह कहेंगे, तो बड़ी चीजें आसान होंगी आपके लिए. The basic foundation of the physician relationship is the communication. Communication can be strengthened by careful and diligent practice. So effective communication can help the diabetes care professional, and it actually link all possible interventions under the single umbrella, and that is कि उसको एक उसको कंफर्ट जोन मिलाएं, उसके साथ सल्यूटोजेनेसिस की जो है वो तरीके से पेश आए, तो पेशेंट जो है वो डेफिनेटली आपको जो है वो अच्छा रिस्पॉन्ड देगा, उसकी हेल्थ इंप्रूव होगी. थैंक यू, जज़ाकल्लाह. Thank you, Jazakallah. And there's another slide. Yes, how ये चीज
I will request our first panelist, Dr. Imtiaz Hassan. I will request Dr. Imtiaz to please share your comments on diabetes distress and its management.
Hello. Assalamu alaikum. Hello. Hello.
So you're audible.
Walaikum assalam, Dr. Imtiaz.
Yes.
Dr. Imtiaz,
I'm online.
please, you're audible.
आपको आवाज आ रही सबको मेरी?
Gigi, we can clearly hear you. Please start sharing your comments.
So I think that today's topic is obviously very interesting and it's the least discussed topic. And most of the time we really discuss how to manage diabetes. We discuss how to manage the complications of the diabetes. And we don't talk about the diabetic distress because the reason is probably we take it as that this is probably the domain of the psychiatrist or the psychologist. And I think it's not the case. And we people, we come across so many patients with the diabetic distress. But before I move further, so because this stress, it has two components. Stress is a normal phenomenon. It's a normal physiological phenomenon. When you are worried, when you are and striving hard, obviously you are under stress. It might be a positive push or a negative push. But when it becomes negative, it becomes distress. So diabetic patient, what we feel is that because diabetes, it's a chronic disease, and usually it is associated with so many comorbid conditions. And most of the time we see our patient, they are angry and they are non-motivated and we advise insulin, they try to avoid it and they don't do the exercise properly as per your instruction and not taking the self-care. And they avoid the appointment. So I see the patient, they're coming to me after 3 years time or 4 years time, and then moving around to different hakims and homeopaths and thing like this. So the last but not least, so their choice is of food is obviously totally unhealthy because of such reason. So they have craving for the foods which are not good for them, and they feel alone at the end of the day. So all these things ultimately they lead to the burnout and the depression. Burnout is, I think, this extreme state. We at time we see the patient, they are totally burnout, they are not taking care of themselves. So, but the depression is obviously it's very very common. But I was talking one of the psychiatrists this morning. So they corrected me and the psychiatrist corrected me that what we call is a depression. It's not actually the depression. It is basically the anxiety. Anxiety means that the patient is worried about so many things because when the person is diagnosed as a diabetic, so he's worried about that probably this is probably the end of one of the very good era of his life. So he's entering to the era of the problems and the thing like this. One of the study has shown that 50% of the people, they are concerned about their visual loss. So they associate the having the diabetes means that probably they are going to be blind after some time. So their kidneys are affected. So, but they are quite scary about the complications. But I think the responsibility on the two parts or two domains. The responsibility of the healthcare professional. So they should listen to the patient. They should discuss the common things. What is the patient problem is, because the lack of the time, most and very busy physicians, they have very few minutes for the patient. If they are not able to tackle the patient, obviously they should seek the help of the concerned person who is an expert in their field. Secondly, we must push the patient in a positive way. So we try to be आपकी टांग कट जाएगी, ये काम ना किया तो आपके गुर्दे फेल हो जाएंगे. This is the negative motivation. So if you tell them this is a positive motivation, that if you have very good control, it means that probably you will have, and certainly you have, definitely you have very good quality of life. You can enjoy your life like a normal person. So that is the reason the most in the developed countries that they are not calling the patient as a diabetic patient, they are calling the diabetic people. Because having the diabetes means that it's a different lifestyle, which is a parallel lifestyle, which is a healthy lifestyle, which everyone should follow. This is not the disease itself. So first of all, you must motivate the patient and you must ask the person to take a break. So you must have a cheat once daily in a very boring way, and ultimately one must have a one cheat day, or one should reward himself at the end of the 1 week or so. And the patient should talk to their family, to their friends, to the healthcare professional, so he can have a kind of catharsis. He can, so his burden of thoughts will be lessened because of the discussion. So obviously, I think the role of both patient and healthcare provider is very, very high. Those patients who are suffering from diabetic distress, and one of this survey has shown that out of type 1, out of 1 into 4 patients are having diabetes distress, and type 2, 1 into 5, out of 5 patients, 1 person is having diabetic distress. But I see the more patients in this part of the world. This is a Western study, and just which I'm quoting. So I think this is one of the big effort and a good effort by your Kafiro sons. So they are discussing that topic which was least discussed, and there is a definitely need to create an awareness among the healthcare professional and among the patient as well. Thank you very much.
Thank you, Dr. Imtiaz. Now I will request Professor Dr. Qazi Masroor, please share your comments, but especially your experience regarding diabetes distress. Dr. Qazi Masroor, sir, can you hear me? Ms. Natalia, can you check is Dr. Qazi Masroor with us or not?
Yes, I'm calling in. Just अस्सलाम वालेकुम. वो आपको इनवाइट किया है फॉर द सेशन, तो आप अनम्यूट. Miss Kiran, he is here. Please unmute him. He is not able to be unmuted.
By what name is he here?
Miss Kiran, can you hear me?
जी अस्सलाम वालेकुम, उज़ैर बात कर रहा हूँ. डॉक्टर काजी मसरूर साहब किस नाम से ऑनलाइन है?
Just let me see. हेलो, आपने जो आईडी अच्छा मैं
Okay, Natalia, can you please mute yourself so that we can ask a few questions from our speakers? So I think there is again a connection problem with Dr. Qazi Masroor. So we can have a question. If you have any question, you can share your question in chat box. So you can directly raise your hand or ask your question from our both speakers. You can unmute yourself if you want to ask any question. So first question is from Dr. Uniba Sayyed. Dr. Uniba, can you hear me? And can you unmute yourself?
I have, Dr. Usman. I've unmuted myself.
Okay, that's great. Dr. Uniba, can you please tell who should be managing a patient with diabetes distress? Is it the physician or endocrinologist, or is it the psychiatrist or psychologist? Or what is your experience and what are your expertise in this regard?
That's a good question, Usman. What I feel is that it's not a disease pertaining to a single speciality per se. So when you're paid, it's sort of a condition which is due to one disease, which is managed by endocrinologist or a treating physician. However, it has a component which needs a psychologist or a psychiatrist input as well. It's not that me being an endocrinologist, if I feel that patient is somewhat in distress, I should just write an antidepressant over it. This is not the treatment of diabetes distress. So when you see that who will be dealing this, it's more of a multidisciplinary approach. It's like we go hand in hand with the patient, the endocrinologist or the treating GP, and psychologist and psychiatrist, either of the two. So it's whenever you have a diabetic patient, there are few other disciplinaries which are involved, like ophthalmology is involved, like nephrology is involved. I think one other that we need to involve is psychology or psychiatrist, so that this thing can be dealt with as a team. I would not put it in the plate of one treating physician or the psychologist only. It can't be treated like that. The main part is of the treating physician or the endocrinologist, who has to make sure, main part is with him or her, that he makes sure that patient is at ease, he understands his diabetes. You can tell him that it's not that the next day you're going to have the complications, and if complications occur, we have drugs that can deal with them, or this is what you expect, this is the target range and with this the diabetes distress, it significantly goes down. When it significantly goes down, you're fine with it. But if you are unable to handle it at that very moment, I think you should take a help of a psychologist as well. There is no harm in doing so. I hope that answers.
Okay, thank you, Dr. Oniba. Now I think Dr. Qazi Masoor is with us. Now I will request Dr. Qazi Masoor to please share your comments on diabetes distress, and please, the most important thing is that you are ex-professor of medicine and dean of medicine. So can you please share your experience, your practical and clinical experience on diabetes distress?
Hello.
Dr. Qazi Masoor, can you hear me?
जी जी बिल्कुल, आवाज आ रही है आपको?
जी जी बिल्कुल, आपकी आवाज आ रही है. Please start.
जी जी. Thank you very much for this very important topic as far as diabetes is concerned and the complication of diabetes, which is diabetes stress. देखें, बात ये है कि सबसे इम्पोर्टेंट तो ये है कि आपने टॉपिक के साथ साथ इम्तियाज साहब से मुलाकात करवा दी. थैंक यू वेरी मच. बहुत अच्छा हो गया था मिले हुए. Whenever we are taking in account the management, everything has been discussed very nicely. मेरा ख्याल जरूरत नहीं है, इम्तियाज साहब ने बहुत अच्छा बता दिया. But whenever we want to manage it, it is the duty of a doctor that he or she should be a very good listener. If you are not listener, you cannot know what the type of things are in the patient's mind which is leading to the diabetes stress. Number one. The one thing has been mentioned that this disease is increasing and increasing, and we are 1 out of 4 are having diabetes. What I start, जब मरीज आता है तो मैं उसे ये कहता हूँ कि यार देखें, ये डिजीज है ही इतनी कॉमन, तो अगर आपको है तो यू आर अमंग द कॉमन पूल. तो बजाय इसको नेगेटिव लेने के, इसको मैं पॉजिटिव लेने की कोशिश करता हूँ. नंबर 1, प्रैक्टिकली मैं बात करता हूँ, बाकी लोग भी ऐसे करते होंगे. सेकेंडली, I try to tell them about 2 or 3 people, known people who are having diabetes. I name one player, जब वो बॉलिंग करवाया करते थे और कितनी इंसुलिन लिया करते थे, एंड जैसे अच्छा उनको भी थी यार, वो तो अभी तक फिट है. ओके, खवातीन वो 2-3 जो शोबिस की खवातीन है, एक्ट्रेसेस हैं, उनके बारे में बताया, ये देखो उनको भी है और उनको पिछले 25 साल से है. पहले तो उनको यकीन नहीं आता. मैं कहता हूँ ये तेरे से भी यार वो खातून है, तो मैं आपसे 20 साल बड़ी लगती तो नहीं. सो आई टेक द अपॉर्चुनिटी कि जी अगर इतनी प्रेवलेंस है तो ये कॉमन डिजीज है, अगर आपको भी है तो बहुत से लोगों को है. मैनेज करना है तो इन लोगों को देख के मैनेज करो जो कि अपनी डायबिटीज को मैनेज कर रहे हैं, शोबिज में भी हैं और खेलते भी अच्छा रहे. एंड देन वी शुड बी काउंसलिंग not only the patient, but we should be counseling the attendant as well. Alhamdulillah, in Pakistan, the attendants are always with the patient. They are not alone. बेटा बेटी होते हैं, बहू होती है या पोता पोती या नवासा नवासी, तो हमें उनको ऑन बोर्ड लेना चाहिए. Then very rightly and just confirmed by इम्तियाज साहब another speaker कि हमें उनकी अच्छी बातों की तरफ तवज्जो देनी चाहिए. अगर किसी ने शुगर को 50 कम कर लिया तो हम कहेंगे जी बहुत अच्छा हो गया, लेकिन असल में तो अभी और करना पड़ेगा. जो आपने मेहनत की इससे ज्यादा करें, बजाय इसको उसको फांसी लगा दें कि जी आपने नहीं की, ठीक है, अगली दफा आप ना आना अगर आपने ये करना. नो 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 नॉट लाइक दैट. If you want to convince for insulin, I think it is not that you should be making a judgmental statement. जी बस ठीक है अभी करना है तो होगा नहीं है, no no. उसको अगर एक चांस दे सकते हैं तो 2 चांस दे दें कि जी हम कोशिश करते हैं, हम समझते हैं कि शायद आप कंट्रोल नहीं कर पाए, तो आप कंट्रोल कर लें और फिर उसी चीज को ध्यान में रखते नेक्स्ट टाइम आएगा फिर आप स्ट्रेस कर उसको थोड़ा सा बता दें उसके बारे में. सो आई थिंक दिस इज नॉट ओनली द who should be educated, it is the attendant patient who should be educated, and top of it, we should have time to counsel them. हमारे पास इतना टाइम होना चाहिए, हम उसको हर दफा एक आध बात पे स्ट्रेस करके बता दें, उसको ज्यादा अच्छी तरह बता दें. Then all the attendant, the nurses, our attendant, the ward boy, the clinic should be aware of the fact कि ये बीमारी लंबी है, इसकी कॉम्प्लिकेशन ज्यादा है, और अगर किसी और को भी हो तो कितना मुश्किल है कंट्रोल में. अगर मुझे भी हो खुदा ना खासा तो मैं भी देखूंगा यार कितना मुश्किल है. मुझे कहते हैं यार ये है ही मुश्किल, लेकिन कंट्रोल तो आपको करना है. वजन बढ़ने की बहुत सी वजूहत है. खवातीन को कहते हैं यार आपकी तो वजन इसलिए बढ़ गया कि आपके बच्चे हैं और उसके बाद आपको दूसरे प्रॉब्लम वो इसलिए बढ़ गए, लेकिन वजन आपने कम करना है. सो इफ वी जस्ट counsel them on each visit, your staff members, our ward boys, staff nurses, the educationists, and the family members, then we can well manage. Because as already discussed, that this diabetes stress will be changing to depression, which will be again a very difficult to manage when you are having people with the disease of the last 20 minutes. So thank you very much for inviting me over here and giving me the opportunity to watch this program and to learn many things out of this program. Thank you very much.
Thank you, Dr. Qazi Masroor, for your valuable comments. Now, I would like to see the second question from my side is for Dr. Umar Wahab. Dr. Umar, can you hear me? Dr. Umar Wahab, can you hear me?
Yes, I can hear you, please.
Okay, Dr. Umar, can you elaborate what is the role of family members in management of diabetes distress? How they can participate in managing a diabetic patient in their family?
You know, family is so important, you know. और फैमिली में जो स्पेशली जो हस्बैंड और वाइफ का रोल होता है वो शायद जो है वो काफी इंपॉर्टेंट होता है. यू नो, यू हैव टू एजुकेट देम, यू हैव टू, आपने उनको बताना पड़ता है कि दिस थिंग विल बी देयर विद यू. डायबिटीज इज नॉट अ प्रॉब्लम के शायद उसको आज इट्स लाइक अदर प्रॉब्लम, अदर जो है कि आपने एंटीबायोटिक दी एंड इट विल बी फाइन एंड यू. डायबिटीज इज अ प्रॉब्लम जो कि आपके साथ जिंदगी में चलेगा. इट्स जस्ट जो लाइफस्टाइल मॉडिफिकेशन है उसको अचीव करना है, और जो लाइफस्टाइल मॉडिफिकेशन होती है वो शायद अकेले कभी भी नहीं होगी. इट इन्वॉल्व ऑल द फैमिली मेंबर्स. यू नो, सारे फैमिली मेंबर्स को अंडरस्टैंड करना पड़ेगा कि डायबिटीज अगर किसी के फादर को या मदर को हुई है तो उनकी फैमिली में आने के चांसेस इंक्रीज कर जाएंगे. एंड देन उसके जी उसके साथ अपनी जिंदगी को और पूरी फैमिली को जो है वो चेंज होना पड़ता है ताकि इसको प्रॉपर्ली मैनेज किया जा सके. और जब भी हमारे पास ऐसे पेशेंट आते हैं इन माय क्लिनिक, यू नो, आई हैव the pre-diabetes का जो है वो एक अलग रूम अवेलेबल है। सो प्री डायबिटिक मैंने एक जो है क्वेश्चनेयर जो है वो डेवलप किया है, जिसमें मैं अपने पेशेंट्स के साथ आने वाले जो फैमिली मेंबर्स होते हैं उनको भी स्क्रीन आउट करता हूँ। और पाकिस्तान क्योंकि यू नो के ऑलमोस्ट तकरीबन 4 करोड़ वो लोग हैं जिनको शायद ये डायबिटीज है, मगर उनको अंदाजा नहीं कि उनको डायबिटीज हो चुकी हुई है। सो इस चीज के बारे में आपने जब तक एजुकेट और अवेयर ना किया तो वो चीजें उस चीजों से फिर इंसान ऐसी फैमिली मेंबर्स जिनको नहीं है आप उसको रोक सकते हैं इन चीजों से। सो फैमिली सो इम्पोर्टेंट यू नो एंड और उसको जो है वो लेके चलना पड़ता है साथ साथ।
Okay, thank you, Dr. Omar. So already we are running late. Thank you of both of our speakers and panelists for your nice comments and wonderful talks. I will, at the end of this session, I would like to thank Formivo Forma for arranging such a wonderful academic activity. So with this, I conclude this session. Thank you very much for your active participation. Allah Hafiz.
Hafiz.